that is behind the problem with the sperm dysfunction and the protein that may have been the cause of that. So if the underlying cause can be corrected, it is possible that that protein perhaps will change its function, and maybe instead of being underexpressed, it might be normally expressed in those sperm samples. So it is theoretically possible.
Okay. I hope we wouldn't run out of time, but I have a last question.
Sure.
You looked at the sperm-specific proteins in the ejaculate only. Did you look at the testicular tissue taken by biopsies?
Not really. I think these are difficult because the amount of testicular tissue that we get during the biopsy is very small. And to conduct the proteomic analysis, you require a decent amount of tissue, because those tissue that we get, we use it to prepare it for IVF or ICSI. So there isn't enough tissue left for conducting the research. And especially in humans, it is very difficult. I mean, if you want to conduct research in animal, that it may be possible, but certainly with the sperm, it is easier because you have a large number of cells in many patients. But testicular tissue amount is very small. You cannot take out a whole testis and give it for research.
Okay. Yeah. Thank you very much, Professor. Now we'll move on to the next presentation. We are delighted to have Professor Ebert Nischlag. He is Emeritus Professor and former Director of Reproductive Medicine and Andrology in University Hospital of Münster, Germany. Professor Nischlag is well-recognized all over the world in the community, medical community, and he also enlightened our research, our literature with hundreds of best quality publications and books and book chapters. Professor Nischlag will address the Klinefelter syndrome, or 46XXY karyotype in males. He will provide an updated overview of this syndrome with its associated infertility, hypogonadism, and comorbidities. He will also discuss the recent tendency to cryopreserve the testicular tissue of prepubertal boys with Klinefelter syndrome for later in vitro gamete maturation. Please welcome Professor Nischlag.
Thank you very much for the kind introduction. I would also like to thank the organizers for inviting me to be part of this outstanding symposium. And actually, my presence here comes out of collaborate work, which we do here as a project on the genetic causes of male infertility. And Professor Beck is the local organizer, so to speak. And you see here our collaborators, Dr. Taha and Dr. Mosley, from the, oops, how do I get back? Yeah, this thing. From the urology department, and Dr. Osama Batuch from gynecology. They are providing the patients. In the first line here you see my collaborators in Münster, and Dr. Abulzena and Dr. Al-Khatani are supervising, organizing the framework for this study. So we are in the process of collecting patients, and I cannot give you really results from this study yet, because we are, as I said, still in the collection phase. But the Klinefelter syndrome is an important part of this, and therefore we are concentrating on the Klinefelter syndrome in this talk now. Now, the Klinefelter syndrome is the most frequent form of sex chromosome aneuploidies with a second X chromosome, which may come from the father or from the mother. And as most of you here in the audience, in both auditoria, I think, are not clinicians, I would just like to briefly give you an overview of the clinical features of the Klinefelter syndrome. The patients are taller than the average male. They have very small testes, and you see this is the case in more or less all of them, 100%. They have gynecomastia, they develop female breasts in a high percentage, and they have signs of hypogonadism, of lack of testosterone. And there are quite a number of psychological and psychosocial problems which may develop already in childhood and in adolescence before the other symptoms are developed. That's why it's important to keep an eye on these children. And finally, they develop, especially as adults, a lot of comorbidities, which I'm briefly going to mention. Now, as I said, the Klinefelter syndrome is very frequent. In the general population, we have an incidence of about 1 to 500 men. We have in our institution, among 23,000 patients, an incidence of 1 to 52. So this shows you that obviously fertility is a big problem. And if we go further down and look specifically at azoospermic patients, then you see that 1 in 8 or 12% of the men are being affected. Now, in the first patients we have analyzed here for karyotype, we have an incidence of 1 in 11 men. That means about 9%. The selection criteria are not only azoospermia, but sperm counts below 5 million. So it shows that obviously the range for these very infertile patients is very similar in your country and in our country. We then looked in the biobank, so to speak, for other Klinefelter syndromes which have been diagnosed in the Center of Excellence, and we looked at the diagnosis behind these 15 cases. And you see here, so this is outside our project. That means that obviously 5 of these cases were referred because there was the suspicion of Klinefelter syndrome. 4 came for infertility diagnosis, 1 for tall stature, developmental delay, microcephaly, ambiguous genitalia, congenital heart disease, which can be quite frequent in Klinefelter syndrome, and finally a fetal case of hydrops fetalis. So you see the wide range of diagnoses that can be associated, and there are more comorbidities that we find. Now, in the next minutes, I would like to concentrate on these 3 topics. And the first one is infertility. And you should know that until about 15 years ago, the Klinefelter syndrome was considered absolute infertile, and it was impossible for these men to induce a pregnancy. And if you look at the testicular volumes in these patients, and you see here a group where we have compared normal men on the right side, the red ones, with the testicular volume in Klinefelter patients, you see that there is no overlap, hardly no overlap, and sheerly by the size of the testes, you can diagnose these patients, or at least you can have the suspicion. There are other reasons for small testes, but the Klinefelter syndrome, this is the leading symptom. And if you look at the testicular histology, then you see quite a difference. On the left side here, you see normal testicular tissue with a normally developed tubule, whereas in the Klinefelter syndrome, the tubules may not be developed, they may be atrophic, and in between there are clusters of Leydig cells, which are responsible for the hormone production. And as spermatogenesis constitutes about 95% of the testicular volume, and the tubules in these cases are so small or are non-existent, it explains why the testicular volume is so small. Now, however, if you look carefully, and we have done this here in a group of patients, then you find in about 8 to 10% rare sperm. So some of these cases have sperm, although they have a 47XXY aneuploidy constellation. But with these sperm, although ICSI would be possible, it doesn't really work, and there are only very few cases that have achieved pregnancies with ICSI. And therefore, one had the idea that one should go into the testis and take testicular biopsies and see whether one can extract sperm from the testes. Because on histological examination, one had noticed that there may be individual tubules that have spermatogenesis, and if one picks these tubules, then one has a chance to extract sperm out of this tissue. And as we for ICSI only need one sperm, or at least very few sperm, it may then be possible to induce pregnancies by ICSI in vitro fertilization, and as in the beginning one has done this at the same time as the biopsy was done, but now we cryopreserve these sperms, and then when the woman is ready, these sperms can be thawed and ICSI can be done. It turned out that it is very important to identify these individual tubules, and this should best be done by microscopy. And you see here a comparison between the normal TESE procedure, testicular sperm extraction, and the TESE procedure with a microscope. And the success rate in terms of pregnancies is higher when the microscope is being used. So although this is much more work, it seems to be worthwhile. Currently, the question is, if there are sperm in the testicular tissue, when would it be best to obtain these sperm? Because there is the notion that the sperm, the spermatogonia and the sperm may get lost very early in the development of the boy. And it may be, that was the notion, that around puberty they still have more sperm than later in life. And we had a series now of 135 Klinefelter patients, and you see the age here on this axis. This line is 19 years, so we separated them into those below 19 and those over 19. And you see that the rate of success in obtaining sperm is higher in the boys than in the adults. And then we were looking for parameters that may be indicative whether a specific case may have sperm or not. And we first of all thought it might be inhibin or it might be AMH, anti-Mullerian hormone, as these are Sertoli cell products. Without showing you these results, we were surprised to see that testosterone is a very strong indicator. Testosterone together with LH, the pituitary hormone, and this you can see here in this field. There the rate is highest in terms of finding sperm, and the testosterone is normal and the LH is normal. Whereas in other cases there is much, when there is too low testosterone or too high LH, the rate of success is much lower. So normal testosterone and low LH is a good predictor for the possibility to find sperm or not. Now, with this approach, it is possible that quite a lot of Klinefelter patients, if they have sperm, get paternity, and the verdict, which until 15 years was valid, that a Klinefelter patient is absolutely infertile, is no longer true. And many of these patients now become fathers. Now let's turn to the second problem, the testosterone deficiency. So testosterone, as you know, comes from the Leydig cells. The Leydig cells are hyperplastic in the Klinefelter patients, and the question is, why are they hypogonadal? Why do they have a testosterone deficiency, although the testes produce a lot of testosterone? And if you first look here at this slide, you see the LH, the FSH here, and we compared this from Klinefelter patients and from other infertile patients. And you see they also have increased FSH, but it's much higher in the Klinefelter patient. The same is here for LH, and now what we should concentrate is testosterone. The orange area is the normal range, and you see that many Klinefelter patients have low, normal, or even subnormal testosterone values. And on the other hand, the question which we asked ourselves was, why is that so? The testes have a lot of testosterone inside, but in the periphery there is not enough testosterone. And we were struck by this paper here from an Italian group where they recognized that the arteries in the Klinefelter patients are smaller than in the normal men. And you see here specifically the abdominal aorta is significantly smaller in diameter than in the Klinefelter patients, than in the normal men. And they did not look at testicular histology, and of course it is difficult to take a whole testis from a Klinefelter patient to look for the vascularization, and therefore we turned to our Klinefelter model, the mouse model of the Klinefelter. And you see here that these animals have a normal genital tract, but they have very small testes, as you can easily see here. So we use this model, and first of all, the serum levels in the Klinefelter mouse are very similar to the serum levels in Klinefelter men. You see here the low testosterone in the Klinefelter mouse, very similar to what we have seen in the Klinefelter patients. And the testis weight is very low, the FSH is high, and specifically the LH is high. And if we then analyze the intratesticular testosterone, although the testes are small, you see that the concentration of testosterone in these testes is the same. And if you use this tissue from the Klinefelter mouse and you incubate it with FSH, then you see even an increased response to the LH, to the HCG. You see even an increased response to the stimulation with HCG, indicating that obviously the Leydig cells in the Klinefelter testes are very reactive, they are normal, but what we then found out that the arterial diameters and the whole area of blood vessels in the Klinefelter testes is significantly smaller than in the normal mice. And we presume now that this is the same case in the human, and because there is so little blood flow through the testes, it is the reason for the low testosterone in the periphery and the development of hypogonadism. Now, if we come to the third problem, the comorbidities, I would like to show you this list of the many comorbidities. Due to time, we cannot really go into too many details, but you see that these comorbidities have high incidences, specifically the metabolic syndrome, diabetes, cardiovascular diseases which develop out of this, erectile dysfunction, osteoporosis, osteopenia, and there are a number of neurological disorders, some of them which develop already in childhood and adolescence. But let us concentrate on the metabolic syndrome and stay a moment with this. As you can see here from our patients where we looked at the incidence of the metabolic syndrome in comparison to normal men and normal women, you see that the incidence is much higher, especially in advancing age. And that shows that these men have a lot of problems because this also shortens their life expectancy. And the question is how this is all connected. And now we investigated whether it plays a role, whether the second X chromosome is of paternal or of maternal origin. And you know that the second sex chromosome, X chromosome, can come from meiosis 1 in the father, or from meiosis 1 or meiosis 2 in the oogenesis on the mother's side. And then you get this supernumerary X chromosome. And the first question was, is this equally distributed, or is there a preference for male and for father and mother origin? And you see here in this analysis that it is half and half in these almost 100 patients where we investigated the parents and then found out where the supernumerary X chromosome comes from. And then we looked, does this have any impact on the metabolic syndrome and on the cardiac problems? And if I show you this result here, if you look at the upper panel first, you can see that if you do ECGs, the QTc time is a very important time as an indicator for cardiac function. And here in this panel you see the normal QCT time in men and in women. And you see here the QCT time in Klinefelter patients, width is lower, significantly lower, and it is even lower when the supernumerary X chromosome is from paternal origin. So that means that the patients with a paternal X chromosome have more side effects, at least in terms of cardiology, than the patients with the X chromosome from the mother. And if you look here, we look here at the insulin resistance, and the question was whether paternal and maternal origin has an influence here. You see the insulin resistance in normal men and normal women. It is higher in Klinefelter patients, and it is even highest in those patients with the paternal second X chromosome. So whether this has any implications for therapy, we do not know yet. But we know, if I make the therapeutic part very short, we know that testosterone substitution has a very beneficial effect on the metabolic syndrome and on the development of diabetes and the treatment of diabetes. And I show you this thing here. Thank you. I show you this study here, which is not specifically in Klinefelter patients, but it gives us an indication how important testosterone substitution may be in these patients. And here you see a group, interesting, from Sheffield, a group of patients from Sheffield who had diabetes, and they were divided in 3 groups, whether they had normal testosterone or they had low testosterone. And those with the low testosterone, they received either testosterone substitution or they did not get testosterone substitution. And you see here the life expectancy over 5-6 years in the patients with diabetes and normal testosterone. And those who receive testosterone, the green ones, they have more or less the same life expectancy as those who started with normal testosterone. Whereas those with low testosterone, which then did not receive testosterone treatment, they had a much higher morbidity and mortality. So transferred to our Klinefelter patients, I think this is quite a clear indication that the substitution with testosterone is not only important to treat their hypogonadism and to compensate for their testosterone deficiency in terms of androgenicity, but that it is for the comorbidities also of great importance. Now with this I want to conclude the talk and would like to summarize by mentioning that the Klinefelter syndrome is the most frequent form of hypogonadism and and it is often overlooked, unfortunately. We consider that only 1/3 of all Klinefelter patients are properly diagnosed lifelong, which is a great pity because, as I try to show, one can help them quite considerably with the proper treatment. And then I would like to summarize that there is a high incidence of comorbidities which lead the patient to the doctor, and the comorbidities are often treated, but the underlying diagnosis of Klinefelter syndrome is overlooked. So it would be very much important that our medical students and medical doctors are better educated in these terms, that they do not overlook these important genetic diseases when they treat diabetes, when they treat osteoporosis, or maybe even erectile dysfunction. Paternity is, thanks to ICSI and TESE, possible today, and one should do it early in life, but not before 15 years, because as you saw in our statistics, in boys under 15 years, the testes are not mature enough to retrieve sperm. And the younger Klinefelter patients should be taken for sperm retrieval, but as I said, not under 15. We should, the testosterone treatment, we should give them testosterone treatment as the most important measure we have now. And I think we should be very careful with children, especially when they have problems of socialization, when they have learning disabilities, when they have legasthenia. It is very important that one thinks of the Klinefelter syndrome, and many also develop ASD like disorders. And finally, I think that the mouse model helps us to understand the pathophysiology, and we have examples for neurological disorders which we also can nicely investigate with the mouse model, and I think in the future this will be very helpful to further elucidate the pathophysiology of this disorder, and then probably also help the patients in terms of therapy. Thank you very much for listening.
Thank you very much, Professor Mischlein, for nice presentation. And the floor is open for questions. Dr. Khalil?
Thank you, Professor, for your talk. I'm just wondering, if we retrieve sperm and we're successful in retrieving sperm, how much of it are we going to use when you're talking about a lot of social problems, of course physical as well, social, autism and all this? Who's going to, let's say, who's going to marry these people? How much of it is going to be useful in the future?
Yes, I mean, so far we do not decide who is allowed to marry whom.
No, I'm not saying, I'm not saying who's going to allow, but who is going to,
No.
It's a social problem,
I mean, I understand what you mean. I think you can look at it from a different angle. If these boys get proper psychological counseling and perhaps medication if needed, they can be well adjusted. There has even been a study now, and there is a larger study going on, which shows that when the boys with 6-7 years already get a mild dose of testosterone, that they are better adjusted than the Klinefelter boys who do not get testosterone. And we are learning, I mean, we always thought that the testes are completely quiet during childhood, but we understand now that they produce a little amount of testosterone, and that may be lacking in the Klinefelter boys. So if we give them proper treatment, very small doses, they may adjust better, and in addition psychological help. So I don't think that these men have a worse chance on the marriage market than normal men.
Okay, I suggest this man can marry X0 female, so they will be neutral. Okay?
Eternal syndrome.
Did I understand correctly that the incidence of autism is 45%?
Yeah.
So how large was that sample, and how come we never heard this as a major cause of
This is-
autism? Which, I mean, Fragile X is considered one of the most common causes of autism. We never heard about
Yes, I mean, I think this shows how little attention has been paid to the Klinefelter child and adolescents. There are good statistics and good publications which show that they have quite a high incidence of these disorders. but they are overlooked. I mean, there are many patients treated for diabetes, and their testes are never investigated. So we know that, but it doesn't happen. And I think we are only slowly learning that the pediatric Klinefelter patient is a very important target group which needs medical attention.
Can I ask a question, please? Regarding the fertility and infertility. So, what is the incidence of getting a Klinefelter, of reproducing a Klinefelter from a Klinefelter father or Klinefelter? And if are they getting children with Klinefelter, or the investigation is expressing that?
It's difficult to
Let me make the question in a different way. I mean, can I make the question when you mention taking the sperms from the testicles of this Klinefelter patient, the sperms will be having 2 X's during the meiosis one?
No, this is a very interesting phenomenon, if that was the question.
Yeah, kind of.
Because the children born to Klinefelter patients so far, they have the same incidence of Klinefelter syndrome as the general population, which means that obviously in the testes there are clones of spermatogonia with a euploid karyotype, and they develop sperm, and the others do not. And therefore these children have more or less all a normal karyotype.
Have you studied the X inactivation? Is completely normal as a female?
Yeah, yes, it is.
There's no difference with a female?
No.
Okay. Considering the high incidence of Klinefelter, do you recommend routine prenatal diagnosis?
I think this is an important question which is being discussed now. And if you consider on the one hand that only 1/3 are diagnosed lifelong, and they have higher morbidity, they have shorter longevity, and they have all these comorbidities, the question is whether there should be an early screening. On the other hand, we now get about 10% of the Klinefelter diagnosed in prenatal diagnosis. And these parents, if they do not opt for abortion, what some do, they come then very early with their young boys. And I think they are the group that need special attention. So our feeling is that a screening would be worthwhile, so that we can detect them early, that we can give them help early, and that they are not going into their adult life without proper medical care.
I think this is true, especially if we use the non-invasive prenatal diagnosis described by Dr. Salman. I have a last question. Before embarking on microtism or the biopsy of the testicle, what's your approach to correct the endocrine problem of these patients? Such patients usually have low serum testosterone, high LH, and high FSH.
I think this is also an important question because routinely, once you diagnose a Klinefelter patient and he has low testosterone, you supplement testosterone. You should, from what we know now, not do this before you have clarified his fertility options, whether he wants to undergo biopsy and perhaps cryopreserve sperm until later in life, or whether he doesn't care for paternity and just wants to get testosterone substitution. Because if you give him substitution, you suppress spermatogenesis. That's a male contraceptive, so to speak. And therefore, it should be clarified before. So this is a very important step in the workup of the patient.
Thank you very much, Professor.
So ladies and gentlemen, we have come to the end of the scientific session, and thank you all for the active participation. Now this session will be followed by the closing ceremony.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I would like to thank everybody, the international speakers, the local speakers, the guests, the researchers, and actually we experience, growing for our activity from the previous conference to today's conference. I would like to thank also the organizers, the colleagues. They work very hard. Different committees working together to accomplish, to make this conference a success. Today we have a lot of discussion with the female side. I mean, they enjoyed so much, and they would like to also deliver a message for the people who organize most of the activities. A lot of thanks. I would let Dr. Adil now announce the winners for the poster session.
Well, first of all, I think everybody has been waiting for this moment. First of all, I would like to thank the judges, Professor Jerry Shea, Professor Albert Furness, Professor Sudhir Kumar, Professor Stephen Shearer, and Professor Anne Goodeve for their effort and their judgment. And now it's time to announce, since they have evaluated the posters, the winners for the first poster. The first prize is Ms. Ulfat Al-Harazi. Ms. Ulfat Al-Harazi, she presented the poster on breast cancer incidence and genomic signatures in young and old women in Saudi Arabia and Western countries, and she came from the Department of Biostatistics, Epidemiology and Scientific Computing, King Faisal Specialist Hospital and Research Center in Riyadh. Please.
That's poster number 30.
Poster number 30. 30. The second prize for the poster goes to poster number 23, and that was on the title Mutational Landscape of Arabian Snuff-Associated Oral Squamous Cell Carcinoma, and that was presented by Mr. Nizar Al-Hibshi. Mr. Nizar Al-Hibshi, please welcome.
Of course, the first prize was 5,000 Saudi riyal.
So the first prize, the winner was 5,000, and second prize is 4,000 riyals. And Mr. Nizar comes from the Department of Preventive Dentistry, College of Dentistry, Jizan University. And the third prize was poster number 105, Integrated Use of Evolutionary Information in GWAS Reveals Important SNPs in Asthma. This is from the Center of Excellence in Genomic Medicine, CGMR, and the prize goes to Ms. Nada Salim. The prize is for 3,000 Saudi riyals. Thank you very much.
Just remind everybody for the workshops tomorrow, start I think at 9 a.m. At the King Fahad Medical Research Center. Yeah, registration will be there Wednesday and Thursday. Thank you so much, and would you like to ask a question?
Workshops. All the workshops will be in King Fahd?
Yes, all the workshops will be implemented in the King Fahd Medical Research Center. Thank you so much. Have a nice day.